Welcome those who are joining us this morning for our Accreta Awareness Month live stream event. We're going to give it a few minutes to let more of our community join, and then we'll get started. While you wait for us to join, please give us a shout out in the chat. Let us know where you're joining us and what brings you here today. Good morning, everyone. We're really excited to have you all here for our Accreta Awareness Month Expert Series event. We'd love to see in the chat where you're from, where you're joining us from. Are you a current patient, a survivor? Are you a provider, or just someone who's interested in learning more about placenta accreta spectrum? Hi, Emily from Kingwood. Chanel, thanks for joining. Hi, Alicia. Well, we're so thrilled to have all of you with us today. We are really excited to bring you this live stream and also to get started, first off, by talking about all of the incredible opportunities that we have available to you during Accreta Awareness Month. I see we have Lisa joining us from Nashville, and she is a provider, so thanks for being here, Lisa. Crystal from College Station, Texas, who gives Dr. Fox a shout out. She says, "You're the best, Dr. Fox." We have Kristen McCain from Indianapolis, a current patient. Chanel, thank you, from Texas, also a provider. This is great. We have such a great mix of providers and patients and survivors. So thrilled to have all of you with us today. Well, without further ado, we're going to go ahead with our event today. My name is Jory Novotny. I'm an Accreta survivor from Columbus, Ohio, and I have the honor of serving as well as a board member for the National Accreta Foundation. So I'm really proud to be here with all of you today for this interactive live stream event, which is part of our recurring Accreta Expert Series. This month, of course, our live stream is part of our larger Accreta Awareness Month campaign. Y'all know that October is Accreta Awareness Month. And there are many, many ways for you to get involved. This is first and foremost a place where you can join us in raising awareness by sharing your story. You can share your story on social media with hashtag Accreta Awareness. If you haven't already, please add your story to our story bank at preventaccreta.org. You can partner with local news organizations, maternal health advocates, and others to increase awareness of what can be done to prevent unnecessary placenta accreta, safely treat placenta accreta, and improve outcomes and experiences for moms and babies over their journeys. We are also underway with the very exciting Virtual 5K, our third annual Virtual 5K, which will kick off in just a handful of days here. This is our biggest fundraiser of the year. This year with registration, you'll get a really cute Accreta Strong shoe charm to keep yourself motivated as you walk, hike, or run 3.1 miles, hopefully decked out in National Accreta Foundation gear. Like this gear, modeled here by Accreta survivor Mackenzie Photography and her adorable son Holden. We've got fabulous new Accreta Mama and Accreta Baby gear, and we also have prizes for top fundraisers. So don't just register for the 5K, but consider using that as an opportunity to fundraise to get your family, friends, and community involved in honoring your journey and in supporting other moms and families. Each year, my Accreta Baby and I bake cupcakes for anyone who donates at least $50 to our fundraiser, which is a cool motivator for folks to share what they're able. But it's also a great way for my son and I to connect and to extend gratitude to the people who continue to support us and to support a cause that means so much to us. I wanted to flag for everyone also that another way you can get involved really easily is by participating in, for example, Amazon Prime Day, which there's a fall Amazon Prime Day tomorrow. If you sign up with National Accreta Foundation as your Amazon Smile charity of choice, a percentage of all of your purchases will go to support our mission. I wanted to give some more shout outs. We have Sophie from England, who's a survivor, and Rebecca from Cincinnati, Ohio. Hi from a fellow Ohioan who delivered in May. Great to have you all with us. So, without further ado, I want to turn you over to our board president, who has been an inspiration for me and many others, who has been part of the helpful information and community that I've found as a survivor through the National Accreta Foundation. It means so much to me to be a small part of bringing expert information to all of you. So let me turn it over to Kristen.
Hey everyone, Kristen Terlizzi here. I'm a Placenta Accreta survivor coming out of Northern California. And thank you so much for joining us here today. And I want to give a big shout out to everybody who's participating in Accreta Awareness Month. We see the posts that you're sharing. We see the pictures of you wearing your gear. I'm wearing my new Accreta Mama shirt as well. Love it. And everyone who's got fundraisers and is getting the word out about Placenta Accreta as one of the fastest growing life-threatening complications of pregnancy. And this month, October, Accreta Awareness Month, is really the month to give back and show your support for National Accreta Foundation through our Facebook support groups that the foundation runs and the amazing work that we do for patient advocacy and support, including bringing incredible events like this straight to you, the patient community. And Accreta Awareness Month is always a big month for us at National Accreta Foundation. But this year, especially, as last weekend or yesterday, we were actually in Utah at the Pan American Society for the Placenta Accreta Spectrum annual meeting, which is the event of the year for the Placenta Accreta professional community. And National Accreta Foundation was a sponsor of the event this year. So I want to say a big thank you to our donors who make it possible for us to elevate the patient experience and show our support for advancements in Placenta Accreta. And so we spoke at the keynote session as part of the patient experience. And our guest speaker today, Dr. Fox, was there as well. So we are fresh off spending the weekend together, and we are so excited to have her here with us today. So in honor of Accreta Awareness Month, I am so excited to welcome Dr. Karin Fox to today's event. She is the program director of the Maternal Fetal Medicine Fellowship Program at Baylor College of Medicine. She's affiliated with Texas Children's Hospital and Ben Taub Hospital in Texas. She is the director of the Placenta Accreta Spectrum Care Team, a board member of the Pan American Society for the Placenta Accreta Spectrum, and also just a tireless advocate for patients in general. We know that Dr. Fox has a large fan club in our patient community, and many Accreta patients credit her with playing a large role in being a positive force in their Accreta experience. So welcome today.
Thank you. Can you hear me?
Yes.
Okay, wonderful. I didn't know if I was unmuted or not. Well, thank you so much for that warm welcome. It is really exciting to see some familiar faces and names, some people who are close by, and a range of patients who are still pregnant, awaiting their delivery, patients who have gone through their delivery experience, and patients from across the world. I mean, we're seeing people from the United Kingdom, from Macedonia. My husband was stationed in Macedonia in the Army and just has really wonderful experiences from that. And so one other thing I'd like to say, I don't think we're seeing my slides yet. Not only was this weekend the Pan American Society for the Placenta Accreta Spectrum annual meeting, it was the semi-annual meeting of the International Society for the Placenta Accreta Spectrum meeting in Frankfurt, Germany. And I also am a member of that organization and zoomed into meetings and lectures for folks regionally in Europe while doing the Pan American Society meeting. And I usually try to go to both events because we do work in very similar fields. We all are trying to understand this disease process better and really reduce morbidity and mortality. And exciting news to come. It may be a little early, but we are in the planning, in the works of trying to host a joint scientific meeting in conjunction with or right around the time of the Society for Maternal Fetal Medicine meeting in 2024, which usually happens in February. That is an annual event where a lot of the maternal fetal medicine specialists get together, and people from other countries often come to the SMFM meeting. So if we're all nearby, we might as well have a joint meeting. So we're going to really try to pull international groups together and really try to collaborate and coordinate.
That
Can I?
is such an excited development. Actually, I want to go through and ask you a few questions
Oh, please
first,
do.
and
Yeah,
then we'll
no,
go
let's
into
go
your
there.
slides.
I'm going to let you lead.
Many of your fans already here typing comments so we can see them, but I want to give everybody else kind of some background information on you and your experience and just what you're seeing in the Accreta treatment world as well. So about how many Accretas do you see a year?
Yeah, that's a great question. And I'm going to say that the number of cases that we see at Baylor, so that's the two hospitals where I work, is rising. But it's not only, and I have a slide that we're going to go over later. It's not just because of the rising incidence of cesarean delivery, but it is because we are a referral center. So, when I first started doing these surgeries about a decade ago, it was maybe 20 cases a year. And this year we are on our way to see well over 50, maybe hit 60 cases. And it kind of depends on what number we're looking at. Are we talking about only the really difficult cases? Are we talking about the cases that are referred to our team because they might be an Accreta, but we're not quite sure when we are doing our initial screening with ultrasound, but there's enough risk factors that we need to be prepared, which is even more patients? Or is it only those that have pathology proven Accreta once we get the surgical specimen out and our pathologist looks at it under the microscope? So those numbers are very different. But from a really practical standpoint, we're screening a whole lot of people. We're really looking carefully with ultrasound, sometimes using MRI cautiously. At our center, we do use MRI selectively because we have really reliable radiologists and protocols to look for Accreta. If your center does not have reliable MRI, a lot of people will argue we should not be using it. We argue that we should use it very selectively and with the ultrasound in mind. And then again, it comes down to how many patients we're managing as the team, or being available for our OBGYN colleagues who may have that surprise case that wasn't anticipated beforehand, or where they're just not quite sure, but they want us to be on standby for a difficult cesarean delivery.
And how does your facility address the complexities of an Accreta delivery from a patient experience standpoint? So kind of outside of the medical care, how do you support these women and their families?
Yeah, that's a great idea. And a lot of it, I'm gonna give a ton of credit to those patients who are in the chat, because really, without hearing their experiences, we can't get better. And I'm going to give a big shout out to Krista Vanal and Leah Gronberg Hood, who are on the chat. I don't know if we've got some of our other folks, but of the people who I can see, they actually got together. Their story is just phenomenal. They delivered at slightly different times at our center. They're both from the same area. I really want them to tell their own story, but they met through mutual acquaintances, and essentially got together and said, "Oh, this is our experience. We wish we could give back." And they started making care packages for patients with Accreta. And we have given out, I can't tell you how many times I've had to email and say, "Hey, we're out of care packages," because we give them out so frequently. And these are for the patients who are far from home, in a hospital that's foreign. It's a stressful time when you're pregnant and waiting. And we acknowledge that. So, I think we've really just come, and we really encourage our team to just acknowledge that there is difficulty in the uncertainty of the diagnosis and prognosis. We acknowledge that we don't always have all the answers, and we are really fortunate because we've got a really robust psychiatry and psychology division within our department. And I recommend every patient goes talk to somebody immediately upon this diagnosis process. I offer it. Of course, we are never going to force somebody to go talk to somebody if they don't feel comfortable. But we want to ensure that they've got a good support system at home, that we give them resources to be able to talk to their family in a rational way, that we can answer questions for their family whenever possible. And it can be hard sometimes, because sometimes maybe the family member is there at a time when I'm in the OR and I can't just go meet the partner or the mother or somebody else in the family. We also give our patients, if they're not in the hospital yet, they're still awaiting that time before they deliver, we give them a brochure with information about what placenta accreta is. We give them a medical alert bracelet that has our clinic number on it. I give them my cell phone number a majority of the time, so that if there's an emergency and they're not in the hospital, at least they're, maybe if they get picked up by the ambulance, they at least know what they have. They're not trying to figure out what happened to this person. And they have a contact. So even if I'm not, as long as I can pick up that phone, I'm not, tied down or on an airplane or something, I can call ahead to our triage area and say, hey, this person is coming in, be prepared, call the team, get everything ready. Or, hey, just admit, we think, we're going to observe and see what happens. So we can at least call ahead and have a plan. There have definitely been times when I've had to get on the phone and say, put the ambulance driver on the phone. I help give them advice, with the understanding that whenever you're picked up by an ambulance, those ambulance drivers and paramedics are under the direction of their own medical officer. And I know this because I do medical transport also. And that ambulance team has to go by their own protocols. All I can do is give advice. They have to clear it with their doctor in charge. I've never had a paramedic or a doctor in charge say no to what I'm asking them to do. But we just want to make sure that, I cannot direct that team exactly what to do. That's not within my scope or my purview, but I can give advice. I can consult. And then I can call ahead though, and to the nearest hospital and talk to the doctors there. As long as I can find it, I can ask the paramedic, what is your nearest hospital? And I can call them and say, hey, this ambulance is incoming and this is what the patient has. And I've done that. I can think of on 2 occasions that in one case where the patient had to deliver locally and then got transported to another higher level of care hospital, and to another where they were able to stabilize the patient and get the patient to us. So it's a challenge. We're talking about people coming from long distances. And while there are things that we can predict, there are some things that we just can't, like when contractions might start or when bleeding might start. It's like trying to predict the weather. But we can have a plan and a backup plan. And that's our goal.
Talk about above and beyond support for your patients. Thank you so much, Dr. Fox. Your commitment is incredible. I have a few questions about you and about Accreta as well before we get into your presentation. Do you think Accreta gets as much attention as it should?
Well, I have a nice slide about that. I think it's getting better.
Oh.
Yeah. I don't want to take too much.
Okay.
Well,
we won't steal your thunder.
Presentation. No, but I was going to say, it is getting the attention it deserves in some ways. What is tricky is getting the funding to do more research from big grant organizations like the National Institutes of Health. Because, when we look at all of the funding in the nation for all diseases, things like cancer get a huge amount, things like cardiovascular disease get a huge amount because they affect such a large amount of the population. When it comes to maternal and child health, we get a sliver, and we're getting more than ever before, which is great. But placenta accreta is a very small portion of all of the things pregnancy related. So for example, preeclampsia affects far more women than placenta accreta. So it's really hard to say that we can get funding. And also because this is still, even though it's becoming more common, it's still a relatively rare and kind of a niche disease process. It's hard to get the funding that we would like in order to do really high quality research. So that's why us coming together as big organizations and doing multi-center research with whatever resources we have is really important. And then looking for philanthropic donors who have a real interest in contributing is so important. And we're, it's a little bit slower of a process that we as clinician scientists would like to see happen. But just like any other marathon, we're taking it one step at a time, and we are dedicated to climbing that hill to make this more robust. I have to give NAF a ton of credit for getting some awareness out there, because if I had a nickel for every time I have a patient say, I never knew this was possible when they get their diagnosis, it's a little heartbreaking. And what is a little reassuring, and not just the people who Google and say, now I know about it. When I hear people say, my doctor did tell me that this could be a possibility if I got pregnant again, or I knew somebody who had Accreta. And unfortunately, I've had one patient recently who said they knew somebody who had Accreta and had a bad outcome before. she delivered with us, and didn't really disclose that until after the delivery. I wish she had said something beforehand, but I don't think she could. She wasn't in a place where she could verbalize it, and that's understandable. But so there is some awareness. And so I think the other thing that is going to be our task is to raise awareness and respect for this disease process without causing undue fear.
Yes.
And it's a hard line to walk, because we want to make sure that people understand what we're dealing with, respect it, go to the right places. But when we drive the discussion just based on fear, then it causes a little bit of a unintended consequence of people just, really having potential increased risk for things like post-traumatic stress or a traumatic kind of experience, or not trusting anybody, which is also hard. Or going back and questioning everything that happened, which is, I think, a natural process and a necessary process, but a challenge. So
Absolutely. Well, with that, let's go ahead and dig into your presentation. I can't wait to see.
Okay, great. Yeah, and let me just go by that. But definitely, I want folks to still put questions in the chat, because we will moderate that. I might not be able to see all those questions right away, but we will definitely address them. And I think that is the most interesting part of the discussion. I would definitely want to make sure that we're answering the viewers' questions and concerns. Okay, so are we sharing my screen right now? Can you all see it? Yes, you can. Okay. All right. I'm going to make this a little bigger. I may not be able to see the chat so much, but you'll be able to see more of the information. Okay, so really quickly, a couple of disclosures. Again, I do have some grant funding about the use of MRI in placenta accreta research. I may talk about or answer questions about MRI, but I'm going to give a balanced answer about what others have found. I want to take out the term ROBOA here in this and just say aortic balloon occlusion, now that there are new brands of a balloon that can occlude the aorta. But we are working on a database looking at this balloon that can block the flow of blood to the lower half of the body, and sometimes we think reduce the risk of bleeding from accreta, but also acknowledge some of the gaps in our research and our knowledge. I've already mentioned that I'm a member of the International Society for the Placenta Accreta Spectrum. They're voting right now to see if I'm going to be a board member, specifically with the education realm. So I don't know, that may happen. We'll see. And I'm also currently the treasurer of the Pan American Society for the Placenta Accreta Spectrum. Okay, so what is this placenta accreta spectrum? Again, it's gone by many different names. It used to be called CRETA, accreta, placental attachment disorder, morbidly adherent placenta, which just sounds terrible, abnormally invasive placenta, and now we've really settled on the placenta accreta spectrum, and this is what most centers are really encouraging people to use, because it is probably the most clear definition. I mean, I joke about CRETA sounds like the name of somebody's great aunt. Accreta, when we just use that umbrella term, it's hard to know, are you talking about accreta, what we used to call accreta, increta, or percreta? Those terms are still in circulation. I'll go over that in a minute, but we're shifting away from that terminology. Placental attachment disorder, that sounds like something out of a psychology book, like, parental attachment disorder. Are you unusually attached to somebody? MAP, morbidly adherent placenta, the argument there was that that's a term from like the 1800s that included just your normally, just retained placenta, and then also those that are really truly stuck and infiltrative. And invasive placenta, we're really moving away from the term invasion, because invasion implies something like a process like cancer. And we've referred to accreta in the past like a cancer, because the placenta seems to be kind of deep in the uterine muscle wall, like a cancer can invade. And I'm going to go over that in just a minute. But we're really recognizing now that may not be how accreta forms. And so those of us who are kind of in the camp that we should really be clear in our definitions, and our terminology should reflect how things happen, really are trying to shift away from invasive placenta. And then it is really a spectrum. I mean, one of the things when we look at the difficulty with, in the spectrum of disease, is that the incidence really varies. Why? Because C-section rates vary across the world. I mean, look at this. Now, this is a little old. It's from like 2013. In the United States, the C-section rate was just over 30%. You've got Brazil and Egypt showing about 55% C-section rates. I will tell you, I was just in Cairo about a week ago at their national meeting, and their most recent data shows that they have a national rate of accreta of of C-section of 74%. So it is very understandable that while it's difficult to get those actual rates of accreta clear, and I'll go over why, it is very clear that when we are doing more C-sections, because that is the most common controllable risk factor, Egypt is just leading the pack. They have so many. And that is one of the reasons why you'll see some publications coming out using data from Egypt. They have a lot of accreta cases. When I was there, we actually did 3 live surgeries that were broadcast to other providers, just to show how we could do the technique and look at the differences in degrees of disease process. So again, the terminology varies too. So again, like I said before, we used to call it accreta, increta, percreta, depending on how deep through the muscle the placenta seemed to be involved. And a normal placenta, I've always said, and I still say this, that in a normal placenta, the placenta comes out as though it's Velcroed in place until it's time for it to come off. Sometimes in something called placental abruption, the placenta actually separates a little early and we can get bleeding. In placenta increta, we see that the placental tissue on those pathology slides, or sometimes when you're just looking at the uterus or the wall of the uterus, it goes about halfway through the muscle, and the muscle is thin, and you just can't get the placenta off. In percreta, we used to talk about it going through the uterine wall into the bladder, but this is where again, folks who are really looking with a microscope are starting to challenge this notion. What we think it is, instead of the placenta actually invading, that what happens is in the location of a previous scar, most commonly a C-section or multiple C-sections, the muscle wall gets very thin. We sometimes call this a window. If the placenta is away from that scar, sometimes we can actually see, for example, the baby's hair or the baby's hand nearby, but it's kind of like you're looking through a translucent window. And I'll tell you, as somebody who's had 3 C-sections, when I had my last one, my colleagues who were doing my delivery said, "Oh, you've got a window. We can see your son's hair." And so I, again, had this risk. But what happens is the placenta, when the baby implants, the placenta implants over the scar, and the usual lining of the uterus that we call the endometrium and decidua is absent. And that's where some of the vessels that help support the pregnancy usually are transformed into bigger pools that supply nutrients and oxygen and maternal blood to the placenta to transfer those nutrients to the baby. But when that's absent, the placenta is a really savvy organ. It is there to support the baby. And it comes from the same cells that ultimately, some of the same cells from the fertilized egg that ultimately develop the baby. So that placenta, those cells will find spaces and find ways to get those nutrients. So what happens is where there's a scar, there's usually a lot of fibrous tissue and scar tissue. And the placenta will then recruit blood vessels from outside the uterus, like between the bladder and the placenta, or the bladder and the uterus, maybe along the side walls where the big vessels go in. And that's where we get this morbidity from what we used to call placenta increta or percreta. It's not so much that the placenta is truly invading. It's not going into the vessels, into the lungs, into the brain, like metastatic cancers, or like a condition called choriocarcinoma of the placenta, or like a molar pregnancy can do. It's a different mechanism. We think it's just landing on a scar, recruiting all these blood vessels near very scarred tissue. And it's that scarred tissue that really makes it, I've always said this, makes it like the placenta is super glued in place. And you can imagine if you're trying to do surgery in an area with super glue and a lot of blood vessels, it's going to be a technically difficult delivery, which is why you need a team. We used to talk about complete, partial, focal, and microscopic. Microscopic accreta, if you hear that term, we think is clinically a very different entity. That is something where the placenta delivers pretty much spontaneously. And then only with a microscope, you see a few fibers of muscle tissue against the placental tissue. And maybe there's a little heavy bleeding in those cases, but you would never see, it's not like the placenta is stuck and you can't get it out. Some studies show that there may be a slightly increased risk for bleeding after having this diagnosis, or a slightly increased risk for an accreta in a future pregnancy, but it is not nearly like it is with multiple prior C-sections or other surgeries. So again, a lot of us in the pathology community, in the clinical community, in the scientific community really think that microscopic accreta is probably a different entity and is much lower on the spectrum. Like, we need to acknowledge it's there, be prepared for blood loss at delivery and future pregnancies, but this is not like having had pathology proven accreta in a prior pregnancy. Focal accreta, that's a loose term. What does focal mean? Is it a whole portion of the placenta? Is it 2 centimeters of the placenta? It's hard to define that. So a lot of us are moving away from focal and trying to actually define how much of the placenta was involved, whether it's an actual measurement or a percentage of the surface area. Same thing with partial and complete. And it's hard to say that there's a complete placenta accreta because, again, almost always there's a little bit of normal area, maybe a portion where there's some what we no longer call increta, but we have some new terminology that we're trying to get our pathologists to use and use consistently, or a portion that's percreta, and that can be all in one specimen. And these terms, accreta, increta, percreta, are from the 1930s and 1940s. So these are really old terms. We're trying to move away from using those terms as our understanding evolves. Here are some microscopic slides that just kind of show some of the differences, though, that where you can see this in the normal placenta here on the left, you can see muscle fibers on the lower portion. Same thing in the right, normal muscle fibers are on the bottom. And then you've got the placental, what we call placental villi and extravillous trophoblasts. Those are some special cells that do the implantation. They're up top here. And there's this kind of what we call a fibrinoid layer here in the middle, where at delivery, this little layer we think is part of what helps separate the tissues. And this was one that was called increta on pathology. And you can see the chorionic villi here on the top, but you don't see this little in-between layer, what we call sometimes the fibrinoid layer, the Niddig-Biggs layer. You just don't see that here. And you can see some little purple trophoblastic cells kind of deeper in this muscle layer. And they don't go all the way through. You don't see them down here, but you see some up here in the inner side. And so this is why this was called increta. Now we would probably call this a grade 2 on pathology based on the newest recommended guidelines. And this is just one portion of the placenta. It's not the whole area, but this is one of the things that we're looking at. In other slides in more recent data, if we do see this fibrin type deposition, this kind of gluey portion that we see really massive amounts of it. And that is where we think we have scar tissue and that glued up clinical appearance. We've changed the name. Again, this is when the International Society was called the International Society of Abnormally Invasive Placenta. We've actually changed our name based on what we understand now. And so this was a grading system that was recommended instead of just calling it accreta, increta, percreta, giving it grade 1, 2, 3, 4, 5, 6. And we've now even changed that to what the International Federation of Gynecology and Obstetrics is using clinical criteria and that pathology criteria. And it's graded 1, 2, and 3, A, B, and C, depending on what portion is involved. Again, I was on this paper, but even the senior author right now who is really keen on looking at the pathology really wants to change this terminology a little bit because, again, we were still using things like terms like invading. And on pathology, we're just not seeing invasion. What we're seeing is scar tissue, a bulge. The disease process is probably the same, but our understanding of how it happens is changing. So don't be surprised if these terms change as we evolve our knowledge base. The big goal, there's a little bit of debate too. There is some real controversy between should we call this increta, percreta, or grade 1, 2, 3, ABC and have clinical criteria, or should we really be purists and only call accreta those that we see on pathology? The argument for using an imaging name or suspicion for screening, it's not diagnosis when we just look at an ultrasound or MRI. We use the term a diagnosis, but it's still not 100% certain. And that's hard. That's hard to, it's hard for us as doctors to say that. It's hard for patients to hear it's not 100% certain. What it is we've got a lot of suspicion, a very high suspicion, a moderate suspicion, or a low suspicion that this is really what we're going to find when we deliver. But that's very realistic. When we say we're certain, 100% certain, that's not quite accurate. I mean, we have to use a little caution and be a little bit more practical there. When we do the delivery, we need some clinical criteria because what we see in the scar tissue that we encounter, it looks different on pathology. And in those centers that are using purely conservative management, where they leave the placenta in place, walk away, wait for several weeks or months for the placenta to either absorb or deliver, or to go back and do another surgery to try to get the placenta out, we won't have pathology to prove. So it's hard to do comparison of those two different treatment types if we don't have some kind of criteria to say this is what was seen at delivery. So we need a clinical grading system. Not only that, but those who are really adamant that we need to stick with this clinical criteria are really focused on making sure that the average clinician, no matter what country they're in, no matter what resources they have, because what we have in the United States, it may differ from in a big medical center versus a small community center that maybe they don't plan on doing a lot of Accreta cases, but maybe they have drop-in emergencies and they have to do something. But it's also going to be very different from what they have perhaps in centers in Africa or in South America or in Thailand or places like that. So we need some kind of clinical criteria to try to standardize what we're talking about. And then we still definitely need some kind of criteria that is very standardized so that we can compare our results across centers based on what we see under the microscope. And so there are some of us who are advocating to change the whole grading system to have just one. And there are some of us who are advocating to use a imaging criteria, a clinical criteria, and a pathology criteria. So that before, during, and after kind of approach is oftentimes what they use in cancer staging. It's called the TNM criteria, or they're moving to a different one as well, but they still have a before, during, and after treatment kind of diagnosis. And that's very useful for prognosing, giving a prognosis for cancer survival or what treatment option is best for that cancer patient. It's challenging with Accreta because once we deliver and once that placenta Accreta is truly treated, even if the placenta is left in place, at some point, we're going to consider that placenta either removed or absorbed or taken out. Then it's treated. So it may not help that individual patient by using this system, but it can help us as clinicians and scientists to try to understand this disease process better and help the next patient. So a lot of us are really trying to hone in on this and get it as clear as possible without changing it so fast that we confuse ourselves and then we can't understand things. Okay, so what's also a challenge about making this a spectrum is it's a spectrum of rates. It's really hard to understand what the incidence really is. And there's a difference. I want to define incidence and prevalence because you may see both terms in the things that you read. Prevalence means how many people in a given population have this disease process ongoing right now. So of all of the people who are logged on right now who are still patients who have not yet delivered and still have their placenta in place, we can count you as the people who have prevalence. Or I can count the prevalence of Accreta survivors, but you don't have the incidence. The incidence rate is how many people have Accreta at any given time. So meaning, prevalence is how much is ongoing. Incidence means how many have happened. So really we should be talking about the incidence of Accreta if we're talking about big studies that have gone on. Now, what is happening? I'm going to use the National Accreta Foundation website as an example of how it can be really tricky to understand the statistics. And this is not to say that this is a bad slide by any means. This is a bad graph. I think it's really important to acknowledge that the rates we think are rising. All of us agree on this. What is challenging here is when we say 1 in 1,250 pregnancies, are we really talking about all pregnancies? Including those who have miscarried, who may have had a termination of pregnancy, who delivered? Or are we talking about all live births? Are we talking about, so it's hard to say, are we talking about only in the United States or are we talking about worldwide? So what's in the denominator really matters. And oftentimes, I'm going to show here, these data come from deliveries at a single referral center. So if we're only talking about one center that sees a lot of Accreta because we're a referral center, of course that denominator is going to be higher because we're getting more referrals in. It's not the easy, uncomplicated deliveries that deliver in a birth center or as a home delivery. Or those it doesn't include pregnancies where people miscarried at 6 weeks and we just didn't, it may not have been a delivery. So it's really challenging. Again, in 1980, when you look at the PubMed data, there were only 4 papers published in 1980 about placenta accreta. In 2002, only 10 papers, 22 papers in 2010, and 44 papers in 2016, and that is growing. So this goes to that question that Kristen asked, is Accreta getting the attention it deserves? I'll tell you, it's getting more than ever before. And so we are paying attention more often. So it may be that we're actually looking harder for placenta accreta because we acknowledge that the morbidity can be high. It may be that we're diagnosing it more. And as I mentioned in those other slides, there are some experts who are saying we're overdiagnosing it. We're calling things clinically that may not be a definition of accreta in the most pure sense of the term, only looking at the microscopic slides, but that where there's a lot of scar tissue, the placenta is bulging out, it can bleed, there can be complications, and still require potentially a hysterectomy for delivery because of the risk for bleeding and other things if we don't take the uterus out. So there's arguments and variability in the data. Now, the other things too, just to highlight how it's challenging, even in 2002, while there are papers that use this number, 1 in 533, I have quoted this myself using this very same term. The ACOG bulletin, the American College of OBGYN bulletin, said that there were 1 in 2,500 one case of accreta in 2,500 deliveries. So not all pregnancies, but deliveries. So you can see how this is a challenge. In 2006, which is the closest to this 2010 data, Bob Silver from the University of Utah was the lead author on a paper that looked at complicated C-sections, and they had really good data. This was one of those papers that helped define that the risk of accreta is higher the more C-sections that somebody has. But they couldn't report exact rates of accreta. They could only give relative rates because they didn't have pathology in all cases. And the billing and coding, where we get a lot of this information from, never included accreta. It showed hysterectomy and previa and C-section, but it did not actually have a code for accreta. This was really a good paper, though, because it did include not just one center, 19 centers that were part of a network of what we call the Maternal Fetal Medicine Units Network. But still good data. And then in a 2021 paper that was as close and even more recent than this 2016 paper, they showed a rate of 1 in 313 pregnancies it was a Japanese group that actually did this data mining using a big database of billing and coding, meaning what the hospitals code for, they write down as the diagnosis and what they bill for. But there are some inaccuracies. We know that when people only use billing and coding, that's not the same as looking at everybody's chart and actually writing down what happened. So again, and some of the numbers of what was called per accreta versus accreta just don't seem to line up with what a lot of people anticipate would be the actual rates based on other data. So it's hard to know exactly the rate, but what we do agree on, and it's very clear, that the relative rates go up as the C-section rate goes up, and we are seeing an increase. So this is why I still very much like this bar graph, because this really does reflect what we're seeing internationally. But if you go back to that first slide where I showed there's a high variety of C-section rates in different countries, there's also a really high variety of reporting of outcomes in different countries. In countries, for example, where maternal mortality may not be considered as high in the list of importance for their major public health centers to deal with, or where women's rights may not be as in the forefront, they may not report on maternal deaths. They may not even count. So again, this is another reason why organizations like NAF or Every Woman Counts are really, really important to help raise awareness and try to hone down on these numbers. And the World Health Organization is really working on this as well. Other risk factors for placenta accreta that are less commonly acknowledged, in vitro fertilization seems to have about a 4-fold increased risk of accreta compared to if somebody just doesn't have IVF, especially when cryopreserved embryos are used. This has been shown in lots of smaller studies, including studies from reproductive endocrinology groups. This is not to say that we shouldn't be doing IVF. It's just one of those things that for those of us who see a lot of accreta, we do counsel our patients, hey, if you've had 3 C-sections before, you need to know that this is one other independent risk factor. Consider it because you may have choices. But not even all reproductive endocrinologists or not all OBGYNs are aware of this link. And so we are trying to raise some awareness. And there are some people who will say it's not a reason to not have a IVF Because again, what we can't control, we know there's an association. That biggest association is if the placenta lands on a prior scar. So if you've already had those C-sections, well, it's already done. We can't take that C-section away. If we could make the embryo land in a certain space, that would be great, but we don't have control over that, whether it's a spontaneous conception or in conception by in vitro fertilization. That little fertilized egg lands where it lands. But we do need to be aware of it. We do need to look at the placenta if you have risk factors, and we do need to just acknowledge that we need to learn more. And so a lot of us are looking at doing just that and publishing more data. And it's really hard to know what's happening in real time. We can only look at these incident rates when we have data from the past. So it's a little retrospective, and we try to catch up. There's clearly differences in teams and in management. I mean, ours is a huge team. We've got a lot of people who we involve. Same thing with a lot of national centers. But one of the things that kind of came up at the Pan American Society and even in the international meeting is when we look at these centers that are considered the experience centers in each different area or region, we're still doing things a little bit differently, which is, I think, addresses some of the questions that I hear from patients sometimes. Why did this person have this treatment and then I had this treatment? Well, sometimes it comes down to what each center is experienced in. There may be that we may not have the resources to manage people with just leaving the placenta in place, or we feel very uncomfortable with that. And we'll have that conversation about what the risks and benefits are and why. But other centers may do that. And we take our experience, we take the approach of trying to learn from all of our partners and try to continuously improve. But again, we get better as we learn over time, and teams that are newer and really gathering their groups together still may have ways to go, but we are actively engaging to make sure that we're helping those centers. And this is a graph of just how teams grow. And this is not just for Accreta teams. This is for maybe a team that's just talking about improving their blood loss, or even if it's a business. Let's not even talk about medicine. If you were a business and you're trying to grow your business and do better, I actually took this slide from a business slide. You may have a launch of your team or your whatever you're doing, and as you start, you kind of slowly get better. You have to have a champion who helps push things forward, and then you grow a little bit, and then you kind of get it to a sustainability pattern, and then you introduce something new. Maybe you have a new way of looking at how you calculate your blood loss in real time, and then you get better. And you grow a little bit, and then you get a little stagnant. You get a little, we've reached a peak where we're kind of doing the same. And then maybe you do some simulation training, or you introduce something else new. You get a little better. And then we start doing feedback to our teams. And this is kind of how we grew over time. But then maybe somebody leaves the organization, and you lose that knowledge, and you lose that until you get somebody new, and then you grow again. So it's a little bit of a non-linear growth pattern, but the goal is to get to sustainability and continuous improvement and reassessment. And then the reality is too, like at some point, I keep joking about, I'd love for somebody to make my job obsolete. If we can get rid of Placenta Accreta, that would be fantastic. I don't see it happening, but at some point in time, I have to acknowledge that I'm going to get OLD. I see my gray roots more and more all the time. So I better be training my up and coming surgeons. And we need to make sure we sustain that quality, because there's lots of evidence of anything that we see over and over again. Experience matters. When we have experienced surgeons, experienced teams, patients do better, no matter what the treatment modality. The way we manage things, even when it comes to things like anesthesia, may be different. We kind of take a two-pronged approach at our center. There are some that really only use general anesthesia from the start, and that's what we used to do. We have more and more data to suggest that using a spinal or an epidural is really helpful in a lot of ways. It helps patients kind of know what's going on. They get to see their baby after the delivery. Babies are more robust. They're not under anesthesia, so they come out crying, and their partners or support people can be in the room with them, at least until we may need to convert to general anesthesia for their comfort. Some places have used like 2 epidurals to try to keep the patients awake for the whole entire time. Because when we start maybe needing to do a hysterectomy, in order to move things out of the way and see, well, it can be really uncomfortable. I've had about 6 patients tolerate a hysterectomy from delivery all the way through hysterectomy with just the combined spinal epidural, but we don't want people tolerating their surgery. We want them comfortable and safe during their surgery. So in most cases, we'll switch over to general anesthesia. Problems are if it's emergent, if someone's already bleeding, if they have a difficult airway, maybe they've got a really narrow mouth, or if they're heavier and their neck is small. I've got a very short neck. I will have a difficult airway. I do not want my anesthesiologist struggling to help my patient breathe during surgery. Or if you're already bleeding and we don't have time to keep you safe, it is best to go directly to sleep for the surgery. And when people are asleep, that's when we have to intubate or put a tube in to help breathe, to keep you safe. So there are times when using this approach will be better, but there are definitely times when we want to make sure we're not doing more than we need to. Okay, I'm going to give a little trigger alert. On the next slide, I have some images of surgery. They're small, but for those of you who do not want to see them, I'm going to ask you all to look away for just a moment. If you feel comfortable, you can always look away. But I have those, a couple of pictures in there just to illustrate some of the differences in different management techniques. And again, I'm not showing any faces, only these are pictures that have been published elsewhere or from folks who have authorized our use of a specimen or a picture. But I do want to at least make sure you have the time to kind of avert your eyes if need be. So I'm going to give you 3 seconds. I'm going to count down to 1, 2, 3. I'm going to change the slide. 1, 2, 3. Okay, here we go. So there are different management strategies where people can leave the placenta in place, walk away, and wait. There are uterine sparing surgical techniques. And I think this is where a lot of things are going. It's not okay for everybody, but sometimes we can just remove the affected part of that scar and where that placenta is bulging through or very close by and stuck, repair the uterus and leave the uterus in place. And that works for, in some reports, up to 80% of the time. However, I'm going to say there is a real bias in the literature. People are only going to report their successful cases. They don't often report their unsuccessful cases. And of course, what most people use, especially in the United States, is cesarean hysterectomy. There was a big international survey of expert centers, and 90% of expert centers use cesarean hysterectomy. So we have to talk about this. And when the other two management approaches don't work, they revert to cesarean hysterectomy. So we have to talk about it. And the risks and benefits I've kind of outlined here. And part of the problem with doing these studies that compare which one is better is that the outcomes are different. For example, in the two treatment modalities on the left or in the middle, they're both ways that preserve the uterus. So we can compare those two techniques. The goals there are to reduce the complications from surgery. They may use other techniques like, using embolization or, stitching part of the uterus to help reduce bleeding. With the conservative management approach, though, is it can take a long time for that placental tissue to disappear or resorb, 6 to 9 months. And then there is a risk for bleeding or infection. And by bleeding, I mean very heavy bleeding, even something called disseminated intravascular coagulopathy, where it can be very difficult to stop bleeding. And it can happen at any time. So it's unpredictable. And so this takes somebody who's very motivated to undergo this technique, who can stay close to a hospital that can take care of them if an emergency arises, and who has very close follow-up for several weeks or months until things are resolved. And it can take, again, like I mentioned, as long as up to 6 to 9 months when we look at the data. The risk for recurrence, if you have this technique, based on studies that have been done and where people have gotten pregnant again, is 22 to 28% of women will have another Accreta. So it's not risk-free. And in the data varies depending on what study you read from what center. Of the women who try this technique, 20 to 58% of women will still need a hysterectomy at some point in time. So it's not guaranteed to work. But it can in some cases. So it is an option. In the uterine sparing surgical techniques or the cesarean hysterectomy, they're both surgical techniques. So you can compare some outcomes there, things like bladder injury, blood loss, those kinds of things. Both are definitive therapy, meaning you take care of the thing, right then and there. Again, the goal for the uterine sparing surgical technique is to reduce surgical morbidity. It may be fertility sparing. That's a secondary outcome. It's not the goal. The goal is to reduce morbidity. The secondary thing is for those people who really may want another pregnancy, it can be done. And again, there are cases, and it's pretty similar. The fertility sparing seems to be about 70 to 80%. But again, there is a risk of recurrence because there's still a scar there. Now, what happens here, though, is by taking out the area that's effective, we may be reducing that area of scarring. So maybe the risk is lower than if you just have conservative management, but we don't know. We haven't compared this yet. And again, it is not possible in all cases. So the people who have done the biggest series using this technique now are finally acknowledging that when the placenta goes really low, really close to the cervix, and we have some ultrasound ways that we can identify this, or that goes really laterally toward where the big vessels go, you may not be able to do this at all. And then you must revert to hysterectomy. Or if the scar tissue between the bladder and the placenta is so tight and so dense that we can't take the bladder down well, we can't use this technique. And you have to have enough healthy tissue between the cervix and the upper and the lower edge of the placenta in order to be able to repair the uterus. If there's no healthy tissue, then the uterus will not come together well, and it will lead to more harm. And of course, with cesarean hysterectomy, this is definitive therapy. It takes away the disease process, but it does require a strong surgical skill set, as does the uterine sparing surgical technique. You may have to open the bladder if the bladder is really stuck. And there is a higher rate of urinary morbidity. We know this. We know that we're more likely to injure the bladder, sometimes the ureter, the tube that connects the kidney to the bladder. But again, this is also reserved in the other two cases for the most extensive disease sometimes. Those who do the conservative management where we leave the placenta in is also oftentimes reserved only for the most severe cases. But again, only reserved, we think it's most successful only for those people who have no bleeding before delivery and where there does not seem to be bleeding in delivery. Because when people have bleeding before delivery, that is one of the signs that heralds that we could have bleeding during or after delivery. All right, other questions that come up, or should we use medications that help contract the uterus? We just don't know, and it's really hard to compare these techniques because the outcomes are different. It's kind of like comparing oranges to apples and apples to pears and oranges to pears. So how do we come up with good studies? That's why we're trying to put our heads together as scientists, as multi-center studies to do this better. And then, of course, most importantly, and I know you all will appreciate this, our patients are very diverse. So the patient experiences, the patient histories, patient backgrounds, prior surgical histories are all very diverse. And so, again, it's very hard to compare. I know I've heard, of course, from patients before who have said, if I had this, why did I have this treatment when somebody else had the other treatment? Why is this my outcome when hers was that? And I would just encourage you to try to avoid comparing with others. I know it's hard, and that's a hard ask, but it really is each individual's journey. And it's not, I think we have to acknowledge that we can't take away anybody's story because everybody's story is unique. We have to listen to one another, hear one another, and support one another as women, as patients and providers. It is very individual, and that can be hard sometimes. And those are the folks who have been my patients before probably acknowledge that I've told them this at some point in time, that these resources too, I think, are so important. The NAF, the online resources, the online groups, super helpful in some cases. If it starts becoming too stressful or interfering with your function or your ability to have solid conversations with your care team, that is when it may be time to just disconnect for a little while until after you deliver and when you're ready, because it can become overwhelming. And so use these resources when they're helpful. When they're not, disconnect. I think that's really important. And I've had patients who at sometimes are able to engage and at other times not able to engage, and that's okay. There's no right or wrong answer, but what I hope that we're doing, both as national and international organizations, is working toward really trying to identify ways to support our patients better. And there are some tools that will be forthcoming. And again, as we as a lot of my colleagues acknowledged at this recent meeting, where sometimes we get a little discouraged, even as providers and as experts, that we can't do this faster. But we are really busy people who are doing a lot of things, and so we are doing the best we can, and we are grateful for the support and the help that we get from folks like you and from NAF in helping us navigate this journey. All right. Again, I'll leave you again with a slide of the FIGO recommendations. Again, this is an international consensus group. And I'll just show you too that when we look at scientific data and evidence, some of it is strong, some of it is weak, but we do the best we can with what we've got. And we are working really hard to show these, to make this better. And some resources, of course, preventaccreta.org, this is NAF, but also these international and national societies. I will acknowledge that passsquare.org, it's very limited, is really designed, that website is designed mostly for our scientific community to engage in. That we are trying to develop resources for patients, and we'll open that website up as we can. But we're working very closely with preventaccreta.org and NAF in order to make sure that we have those resources. But there are some patient brochures too on the ISPAS website, so I want you to be aware of that in different languages. So if you are, again, in Macedonia and you speak Czech or Russian and you know somebody who can translate these, we are updating this brochure right now, but we have this in different languages so that you can hand this to your doctor or your provider, even if you speak a different language. And this last one, I'm going to just caution you all, this last link is for your doctors. It shows in very clear detail surgical procedures. It is not for the faint of heart. It is surgical. It is techniques. It is very high detail of what we do in the OR. So it is not just for patients and providers, unless you have reached that point where you really want to know what we do and you want to see it. It is real videos that were compiled at the University of Oxford by one of my dear friends, Sally Collins and Human Solmayani, her gynecologic oncology colleague. And they're very good instructional videos, but they are not intended for patient viewing. They're intended for surgeon viewing. But that said, that is the end of my slideshow. I want to focus now on questions, comments, and a discussion.
Thank you so much, Dr. Fox. Oh my goodness, that was incredible. I do want to give a shout out. Thank you for putting National Accreta Foundation website out there. And one of the things that we're really excited about with the Pan American Society is we have issued some joint communications.
Mm-hmm.
So on our website, we have a second opinion article, and we're definitely working on more collaborations like that, where we can get information out to the patient community that is blessed by you guys, the latest and greatest information, and also accessible and available to the folks who need it. And that talk was fascinating. Thank you so much for just capturing all of the information out there about Accreta. I mean, we say there's not enough, but there's also so much of it. I'm really being able to distill it down and translate it for us. I thought that was fantastic. So thank you.
Thank you.
I have one question that I want to ask you too, is does the placenta stop growing at a certain point? So often if people are diagnosed maybe in their second trimester, there can be this question of, gosh, the longer that I wait in my pregnancy, obviously we don't want to go into labor or anything like that. We want to make sure the baby gets the best chance at a good outcome. But also, does that mean that the placenta is still continuing to grow throughout that duration?
Great question. Okay, so here's what we really think. And again, this kind of goes to the concept that this is not an invasive disease. It's not like it's digging in and burrowing in. That's something that happens. There's a little bit of physiologic implantation where just only certain cells do a little bit of invasion in the beginning, and then the placenta stays there and starts growing. So it gets bulkier as the baby grows, but it doesn't necessarily continue to grow deeper. We think there may be a little bit of a physical, mechanical expansion of that scar as the baby grows and the uterus stretches, but that's very different than really infiltrating. And I'm going to tell you a story using no names, but we had a very savvy patient and her partner who, and I've heard this from more than one person. We do think that some of you may have heard of cesarean scar pregnancy, or maybe you were told that your Accreta started as a cesarean scar pregnancy. We really can see that sometimes in patients who get a very early ultrasound if we recognize it. It's low, close to the cervix, and usually it's a little offset near the bladder. And because the little gestational sac, what we could call the gestational sac, is really small, it may be above what we call the uterine lining, or the lining of the cavity, the inner surface that we can see kind of as a line on ultrasound. And so if it's like here, like normally it's up here on the top of the uterus, if this is the cervix, that's normal. If it's down low, the most common thing that we think about is impending miscarriage. So some people have been told, oh, you're having a miscarriage on their first ultrasound, because they come with spotting really early in pregnancy. Oh, you're going to miscarry, but they don't. And then later they're told, oh, you have an accreta. And then they're told when they get another ultrasound, oh, it looks like percreta. And so it can sound like this is invading more and it's getting worse and worse and worse. What probably is happening is it's getting recognized, and we're using that old terminology of what we think, how involved the placenta is, or how vascular the placenta is. But what we see on the cesarean scar pregnancies, if we recognize it, is that it's not just low, but offset. And so there are some predictive ultrasound findings that, we call this a crossover sign, because the implantation is crossing over that endometrial line. And if we recognize that, sometimes it can be treated right then and there. It means that the pregnancy would not continue like an ectopic pregnancy. For those pregnancies that have continued on, 70% of women can deliver in the third trimester, but there are, again, that leaves 30% of women who may have bleeding, uterine rupture, massive hemorrhage, and need to have an emergency surgery before they make it even to what we call viability, before a baby can survive. And we know this happens sometimes. It's really tragic. But again, this is where planning and having a safety plan is so critical. I see a lot of comments in the chat, if I can just address a couple of them.
Yeah,
about,
we're jumping in.
about having a backup plan. So again, my doctor had a prior massive team meeting with all who are going to be involved. Thank goodness. A written plan for the hospital if you're ever to come in. That's exactly what we do. We have big team meetings. We have a multidisciplinary plan. We put it on the chart. We give our patients a medical alert bracelet. You have plan A, plan B, plan C. And sure enough, it sounds like something happened. Absolutely really critical to have that kind of planning, no matter what the diagnosis is. And again, I saw somebody else living, again, I'm going to give a shout out to the people who came to the hospital via Kangaroo Crew. Hopefully, again, they better treat you right. If they don't, you tell me. We'll work on that. But no, again, I have full faith in our ambulance services. The challenge is, though, too, again, the folks who live not just an hour and 45 minutes away. We see that in just Houston area alone. It can take 2 hours to get from one end of Houston to the other. But I really, and I acknowledge too, I show a slide to some of our international colleagues that Texas covers most of the size of Europe. So we cannot compare our outcomes to the outcomes in France or the outcomes in the Netherlands. Like, we can compare the outcomes of Houston to the outcomes of France, or the Netherlands, because that's about the same size geographically. And it's not just how far somebody is away, it's how much time it takes to get to the hospital. So for our patients in Houston, I ask them, how long does it take you to drive here? Because and they all say it depends. I can be 20 minutes with no traffic, but an hour when traffic is bad. And that's a very different scenario if you start having an emergency at home. And I've had those patients who I've told you can't go anywhere, and they say, oh, I'm not going really anywhere, but they're really far away. And when I get that phone call and it's like, oh, we're 4 hours away, it's really challenging. And it can be hard to understand. If you feel fine, I feel great. Yeah, let's go on that family vacation. Yeah. It's hard. It's hard to comprehend that this is really serious. That's where I say I want to have that very fine balance between respecting what we're dealing with. And I've had patients too, who have said that they heard what I said, but they really couldn't believe what I said until that this was real, right? It doesn't feel real if you feel fine until something happens. And that's a natural response to an abnormal circumstance.
That's so true.
Yeah. I also want to address the comment too about only having had one C-section and having this disease process. I've seen it. This happens. Yeah, exactly. I mean, and it's hard, even though, okay, so this is the same kind of phenomenon with odds and statistics that is hard to wrap our minds around. And we're really, like, we as human beings, I'm not just saying patients or doctors, but we as human beings are really bad. There's really good evidence at this, really bad about really accurately predicting our risk. Meaning, it's really easy if you've had, maybe some risky things, but you've never had a bad outcome, to say that it's going to happen to me. I'm going to be that one. Or on the flip side, I've had some patients who have had some real complications in otherwise normal pregnancies. And so for them to hear, I don't think your risk is high, they don't believe you until they make it through with a uncomplicated delivery. So, and I get it. It's like, it's just hard to believe that yet, or they think I'm going to be the one. I just know it. And I was actually one of those people too. I just knew with my third pregnancy, and this is I'm not trying to make light of this. I really did have that knowledge. I was a resident when I had my third, and I'd already had 2 prior C-sections. And so I knew I had the potential, and I was over 35. I mean, I met all of the boxes. I was, again, having advanced maternal age is another, that was the classic risk factor for Accreta before we ever had ultrasound and all these C-sections, was advanced maternal age and multiple prior deliveries. And I somehow had myself convinced that I had a baby with Down syndrome because I was over 35 and Accreta until I had all of my screening, and it seemed like the placenta was away from my prior C-section scar, and the screening looked okay. Which is not to say I didn't have complications. I did have that window. I had that very thin scarred area. And I had to go get delivered early because I was laboring. And so our knowledge base, our perception, having known somebody who's had something happen can really affect our perception of what is going to happen to us. And it does drive our decision making is oftentimes not drive by logic or Dr. Fox or any other doctor telling you what the rates are. It's really driven by our emotional perception of what we fear most, what we want most, and what we've seen. And so, for example, I'm going to use my own story as an example. When I was pregnant with my very first baby, I can actually remember being a little terrified of delivering vaginally because I knew somebody who had had a horrible 4th-degree laceration. That's where the vagina and rectum tear. And she had permanent rectal incontinence of stool. And I knew that my baby was a little bit bigger. I knew I was going past my due date. I ended up going into the hospital when I, ended up actually getting admitted into labor, spontaneous labor, almost fully dilated. And so it seemed like I was okay. And this is when they actually wheeled you into a different delivery room. And they said, oh, it's too late for you to get an epidural. I cried a little bit that too, because I'm like, oh my God, no, I'm not going to have an epidural. But it was time to push. But then my midwife said, no, you can't push. You've got a lip of cervix that's still there. If you push, it's going to cause more harm. Went back to the labor room, did get that epidural, which made me much more comfortable, that's for sure. But then I waited for several hours, which is not our standard of care anymore, but hours before they called the doctor and said, they did all the tricks, broke my bag of water, watched her heart rate, gave me Pitocin, all the things to try to get my child to deliver. Wouldn't fit. And then she started having heart rate dips, and they said, we really think we need to do a C-section. And by that time I was like, what are we waiting for? Come on. But, and there's no way she would have fit. She was just too big for my pelvis. And thank goodness that my care team did that C-section that allowed her to deliver safely. I mean, and we're talking hours. We give people more time than ever before, but this was a very long trajectory. Had we continued on that path of trying to get her delivered vaginally, either she would have had brain damage or death. I would have likely had infection or might have lost my uterus because of infection or heavy bleeding. And we both came out okay. My second baby, I knew was huge. Like, I felt bigger. She was my largest child. And I was in a center. I was in an area where my doctor tried talking me out of a VBAC. But I also told him, you don't have to talk me out of this. First of all, I didn't want to go through laboring all the time and then ending up with an emergency C-section. But I knew this baby was bigger than my first. If my first couldn't fit, this one is not going to. And I knew that I was in a hospital where they did not have 24/7 anesthesia. And so if my uterus ruptured while trying to VBAC, it would have been a disaster. Had I been in a different center where they had 24/7 anesthesia, that's why he tried talking me out, not because he didn't want to do a VBAC, but because he knew that the safety risks were higher than the benefits of trying in that center. And that's just because I was in an area in medical school where they could not have 24/7 anesthesia. And with my son, of course, by then it was like, this is not, and there's also good data that if you make it to 9 centimeters and you stall out there or completely dilated, your chances of successful vaginal birth after C-section are less than 13%.
Wow.
So you have to work, and we have calculators now that calculate your risks. It's not zero, but we really have to be practical. We need to offer safe VBACs, not just VBAC at all cost. And we need to be very, we have to recognize that there are risks and benefits and unintended consequences of all our decisions. If we say we have to get rid of all C-sections, we're going to hurt moms and babies. If we
Absolutely.
only offer VBACs, we're going to hurt moms and babies. So we have to be very careful about it. And we have to kind of, the analogy I use is we as providers have to be the navigators down, say, a whitewater rafting trip. The patient, you're in your own boat, you have to steer. I have to tell you, I need you to paddle harder and I need you to steer right now to avoid the rocks. I need you to slow down and turn left in order to avoid the waterfall. And we have to meet both ways. And kind of that's, I think, what we do.
Going back to the risks and benefits, though, one of the things that I think is so interesting about Accreta is that the majority of us got into this because of our prior history of a cesarean, yet a cesarean and access to appropriate level care is such a necessity for surviving an Accreta pregnancy for both our babies and ourselves. So I think that just the experience of Accreta illustrates the appropriate places for the cesarean and also potentially the unintended risks, right?
Mm-hmm. Yeah, absolutely. Yeah. And I want to address that too. So, because I'm seeing some other chat too about, being a level 3 maternal level of care center. So, there has been a push at some of the national levels to designate levels of care for maternal care, just like we do for neonatal care, like a level 1, 2, 3, 4 NICU, where level 4 is the highest level of care, or trauma care centers, where level 1 is the highest level of care. And so our maternal paradigm mimics that of the NICU. So level 4 would be the highest level of care. In the state of Texas, that is now part of Texas state law, that centers have to be designated by maternal level of care. And so we actually have people come in, independent reviewers, look at all of our policies, procedures, our notes, what we actually do, and they determine, do you meet level 1, 2, 3, 4 level of care, which is a great way to know this is a center that has a lot of resources. This is a center that has almost all the resources. This is a center that really should deliver most common deliveries, but can do a little more. Or this is a center that only can take the most basic, healthy, routine pregnancies and transfer quickly if complications arise. And just this year, a bill was passed in the state of Texas to designate certain centers as level 3 PAS or level 4 PAS centers. And it's challenging because while that's a great way to know exactly where to go if you plan on doing these deliveries, it also limits the number of centers that routinely do them. And it means that our patients may have to travel further to get to those appropriate centers. But that is one good way to identify those centers. Most centers that are big academic centers will have the resources to take care of placenta accreta. But this is where it becomes really important to log on to places like, one way to look, if you look at the Pass Squared website, we have listed our institutional members. Those are the members. They may not be all the centers that are doing Accreta care by any means, but those are the centers that have joined forces with us to try to collect data, to do research, to participate in understanding more. So they're going that extra mile to understand things. There's a lot of us who really believe we need to be moving toward reporting our outcomes. And that's a hard ask for hospitals to do. Nobody wants to say, hey, we've had these complications or we've had these challenges. But a lot of us feel that it is really important. And I tell our patients flat out, like if they ask, I will tell them exactly what our outcomes have been. And I also warn them, I'm going to be really honest with you. I'm never going to lie to you about these things, but you need to be aware. Whereas, sometimes it's hard to say, nobody wants to say we've had these outcomes, or a lot of people advertise we've never had these outcomes yet, is going to be my concluding statement. We know these things happen. It's really challenging, but we have to be honest about it. But that's one way to kind of, and if you look at our joint get a second opinion document, we say, ask your doctors, ask what their outcomes are, because that's really important. And as far as the question about, do we have a tool for screening? It's not a true tool. There is one tool that I'd like to leave you with, and I'm going to ask you to go either email me afterward. This is for Emily. for the maternal program manager. There is a screening tool that I find very useful it's from a European working group. There has recently been a study to validate this tool, but it has some clinical history data, and it has some ultrasound imaging findings that can help clinicians, first of all, prime their minds for this patient might have Accreta and look for signs of Accreta on ultrasound. And then it prompts that person who's looking at ultrasound to say, I think this person has a high, medium, or low risk of extensive or focal Accreta. And that really, it's a useful tool. I find it useful. We're validating it. But at the same time, there's also another article that Bob Silver and I and some others wrote about what constitutes a center of excellence. We don't use that term center of excellence that much anymore because that has a very specific definition for Medicaid that involves reimbursement. So we're trying to move away from center of excellence to Accreta centers, right? But it essentially lists what the center should have and the patients who you should refer, whether for screening, like if somebody's had 3 or more prior C-sections, a C-section with a placenta previa, any other big surgeries in a pregnancy, or anything that looks abnormal on ultrasound that makes you think, I don't know, you should refer them for another opinion or for delivery. And so it depends. Like if you just do not have a good blood bank, if you're questioning whether or not you've got 24/7 coverage, if you're just not sure, it might be Accreta, it might not, but we just don't feel comfortable if it is, refer them. I mean, and it's really quite simple. And there is a new document that is coming out too about what to do for the unanticipated drop-in emergency case. There is one that the SMFM, the Society for Maternal Fetal Medicine, already has, but there's a new one coming. So be on the lookout for that. It should be published within the next couple of months.
Fantastic. Jory, I believe you got some questions that were submitted in advance of the event as well. So let's see if we can go through a few of those.
Yeah, we got a great one that I think crosses over your 2 areas of expertise in a unique way. So Chanel asked, in the event that an unexpected procreta is evident, the recommendation is to pack and close and transfer to higher level of care. Who are the team members involved in the transfer? Is it realistic?
Oh, great question. And this is from Chanel Gonzalez from McAllen?
Yes.
Okay, great. Yeah, well, that's a great question. It depends on who's transporting the patient, right? And is it realistic? It depends. You have to have a patient who is stable. If the patient is not stable, you can't do that, right? Unless I will tell you that we've at least our team has definitely taken a patient from out of state who was in a Catholic hospital, actively bleeding. By actively bleeding, not hemorrhaging, but bleeding enough that they've had to transfuse multiple times, and who was what we call pre-viable. The baby was not old enough in gestation to survive, but this mom was clearly not stable enough to stay in that hospital where they were told, because it was a Catholic hospital, there was no way, no how that they were going to be able to deliver before viability. And so that this mom was really at risk for dying because of blood loss. And so we had a team meeting and we determined we will allow our maternal transport team to go get the patient by plane with blood in the cooler, knowing, and I'll tell you, our team was nervous. They were anxious. We had a L&D nurse, a critical care nurse, a respiratory therapist, and a paramedic, and of course the pilots on that team. We didn't send a doctor. Why? There is no way we can do a surgery in a plane. And we have to make sure that our doctors are on site, ready to accept that patient. If we send the doctor, it may actually dilute the amount of people who are here in the hospital to receive that patient. And of course, our team will assess the patient upon their arrival, determine, and if they say this patient is not stable enough for us to put on the plane, we will have a conversation with the doctor on the ground and say, we do not think this patient is stable. This patient we had blood ready. They gave us other product. We got her to our center. But this was a discussion of the risk-benefit ratio. If the patient stayed there, the doctor who called us said, I am fearful that this patient will die at our hospital if we do not move her out. It is very highly likely that this will happen. And we had to have that conversation with our team saying, here's the risk. Here's why you're going to go get her. And we told, and the patient has to be consented about this. Bad things may happen on transport. So if you're getting on an ambulance going from hospital to hospital, it's very likely you are signing a consent form saying, I know that I might have a bad outcome. I might get worse and things may happen while in transit. Read the fine print when you sign that form. But the doctors who are talking are really trying to get you to that higher level of care. And of course, we're using the fastest method possible to get the patient to us by helicopter or airplane, not just traveling. And then, of course, she got to us safely. Her bleeding was heavy enough that we did feel like we had to do her hysterectomy as soon as she landed. I was incidentally out of town when this happened. So it was my chair, who was also part of our team, who did the delivery. Laws are changing, of course, we know, across the country, which is a challenge. And this is a little bit of a sensitive topic. Most laws still permit a delivery, a hysterectomy treatment if the life of the mother is at risk. Talking to some of my colleagues in some states, it is not exactly clear that that is the case. If there is still a heartbeat and a live baby, sometimes what we have to do is we have to, as clinicians, we just have to bite the bullet, do what we think is safest for the patient. And then we have to prove that, yes, this was medically necessary in some states, not in Texas. But even in the state of Texas, there has been some concern, like, are we able to resect that cesarean scar pregnancy, or is that a termination, especially if it's after 6 weeks? And most of the time we don't diagnose this until after 9, 10, 12 weeks. I will tell you, I have done surgeries for patients who are actively bleeding and at risk for hemorrhage or in DIC before viability. And I have not regretted it. Because I know that I would have lost those patients, even though it means devastatingly for us as well as providers losing the baby. But I do not want to leave a child without a mother or a husband without a wife because we're trying to push the limit. And so this is where we need some advocacy and some voice to help make our laws a little bit more clear and a little bit more rational when it comes to these very, very sensitive topics, because I will tell you from a provider standpoint, it is not clear. And I'll just leave it at that. Hopefully that answered the question. Here's the other thing I'm going to say. Let me get back to the transport question. Is it feasible? Sometimes it's feasible. Sometimes it's not. If your patient is stable, yes. The other challenge with, especially helicopter flight, if the weather is bad, the helicopters may be grounded. You may not be able to transport. So it is really critical that you look at what other centers you have and try to get your patients there early. I really try to work with our providers in Texas who are far away, who refer patients. If I can't convince the patient to get to Houston earlier, and sometimes it's hard, they may not have the resources to do so. I'll tell you, we had a patient from the Rio Grande Valley who did have resources, or who made it happen. I don't know how she did. And we tried helping her, but whose husband quit his job so that they could be nearby, so that they could continue their pregnancy for months at a time. And I cannot imagine, but they had the ability to do so. Not everybody does. And that's really hard. So that's where we can advocate and ask. We had a meeting at the Pan American Society saying we need to get billing and coding better so that insurance companies are reimbursing us. For example, the reimbursement for one of my colleagues for a cesarean hysterectomy for Accreta, they got paid less than for doing a tubal ligation. That makes no sense.
Oh my goodness.
Does your insurance cover your hotel stay if you're staying near a center that will deliver you appropriately? Probably not. Do we admit you in the hospital to keep you safe? I've had patients whose insurance companies have said, we're not going to authorize this payment. And I've had to get on the phone and say, let me send you this data about why we think this patient needs to be here. And oftentimes they'll then cover it, but not always. And so that's where NAF can also advocate for our patients, saying, we need insurance companies to step up. It's much less expensive to pay for a hotel right across the street than to pay for a hospital room. And when a patient is admitted to the hospital who's stable enough to stay right across the street, but is in the hospital, that's one bed for another laboring or ill patient that we don't have, or for that emergency transport. So that's the other problem. So right now, our hospital, we've been on what we call census alert. We are full. We're a level 4 center and we are full. And so if my colleague in McAllen calls and says, hey, I've got this urgent transport, but we're full, I have to say we are on diversion. I cannot accept another patient, or we make it unsafe for all the patients in our hospital. And we never want to get there. So we have to find smarter ways to take care of everybody. This is where that ethical concept of justice, taking care of everybody in a fair manner, comes into play. And it is really challenging. We have competing interests. We don't want to do harm. We want to do good, but we also have to make sure it's fair for everybody.
Yep.
Wow.
Jory, do we have some other questions?
We got one about risk factors, and you had talked about in your presentation about obviously that everyone agrees that there are links between increased C-section rates and increased rates of placenta accreta spectrum. And you also talked about IVF. Heather asked, how common is it for a woman to get placenta accreta without having previous C-sections or a uterine surgery like IVF? She asked, for example, could an IUD cause an accreta?
Oh, great question. Okay, so we actually have a paper in process that we've been trying to get published. It's hard to get this published though. What I'm going to share the data prior to publication though. We did find a very, very, very slightly increased association. I can't say it's causation. We can't prove causation based on the data we pulled. And meaning it definitely caused it. What we can see is we saw a very small association. If a Mirena or other hormone-containing IUD was pulled, and then the pregnancy occurred within 1 month of pulling the IUD. But it was not enough to be significant. It was not enough to say you should not have an IUD, because the reality is if you've got C-sections and other risk factors and you get pregnant, well, that's a big risk factor. If we keep you from getting pregnant, that's protective. So those of us who are in that camp of the women who want to know and minimize their risk to as low as possible, will tell our patients, hey, you just have this Mirena IUD pulled, maybe wait a couple of months before you get pregnant. That's reasonable. But I cannot prove that all pregnancies within a month are going to be accreta, because that placenta may land anywhere, not just where the scar is. And again, like I said, we're using billing and coding data from a very large insurance database. So we're not going back in the patient's chart and looking at all of the factors that may come into play. And the signal was not that strong. It was much less, for example, than what we see with IVF pregnancy. And it was far, far less than what we see with cesarean delivery. And it was very, very low anyway, even for that 1 month. So while we want to say it may be there's just not enough data to prove it. And we've really been looking for several years. I know it was a patient who asked me this question before. And there's some what we call biologic plausibility. It kind of makes sense based on the way that a hormone secreting IUD might work. But we just cannot seem to prove it.
Tiffany just asked in the chat that her 36-weeker was born healthy but small. Her report stated that the placenta was half the size predicted, and she was curious if that's why the baby was smaller.
Yeah, that's great. I'm also looking at her previous comment about having high blood pressures before delivery. We know that small size of babies or poor growth is associated with high blood pressure. It can happen in women who have chronic hypertension, meaning blood pressure before pregnancy or early in pregnancy. It can happen sometimes we see the small growth, and then later on people start having blood pressure problems. And we think they're linked. We don't know exactly why. What is interesting is we have really good data showing that growth, both from the international literature and from our own data as part of the Pan American Society, the placenta accreta does not seem to negatively impact growth, meaning babies tend to grow just fine in accreta moms, probably because they've still got that robust blood supply and nutrients. However, if you also have some high blood pressure issues, that may be associated, that may be the reason why there may be still some small growth. There is some evidence to show that not that accreta is protective, but we see a little bit in some studies, they see a little bit less of an incidence of high blood pressure or preeclampsia with accreta. There's another study that we've just looked at some of the international data, and it seems to be pretty similar rates of preeclampsia with accreta. Now, if in the very small group of women who didn't get diagnosed with accreta and made it to 37 weeks or beyond, that's where we're seeing a little bit of smaller babies at delivery with accreta. But again, that may just be a reflection of the fact that most of our patients deliver before 37 weeks.
I think we might have time for one more question. I wonder, maybe we could close on kind of a bigger picture, zoom out question, just about, we've spent a lot of time talking, of course, as because of your role, you're seeing cases that have been diagnosed, have been flagged as likely for accreta. But what would you say are choices that a provider that encounters an undiagnosed accreta at delivery could make, or maybe not make, that would make or break their success in preventing the worst case scenario? What would your recommendations be for someone who's much more inexperienced with accreta for them to do in those critical moments?
Yeah. So just such a great question. So again, and this is what a lot of my colleagues would probably say. I know some of them are also on the line. Again, try the best you can to diagnose it early. I will tell you, I've had referrals where maybe somebody was being managed by a family medicine physician who doesn't do a lot of ultrasounds, but they do C-sections. And then the OB gets consulted to do a quick scan the day before delivery at 39 weeks. And the OB looks and says, oh my gosh, this does not look normal. I think she might have an Accreta. Stop right there and refer the patient. There's no harm in that. If the patient is stable, not bleeding, do it then. And we've accepted those transfers. You may have, again, which got referred to by Chanel, maybe you start the delivery and you see what looks like Accreta. If the baby is stable and the mom is stable and the uterus looks really abnormal when you open the abdomen, stop. Close the abdomen, transport the patient then. You don't even have to pack. I mean, if you haven't caused bleeding, stop. The other thing is if you're doing a C-section, for example, and you see, like maybe you have to go. Maybe the patient is bleeding or, the baby's really, there's concern for the fetal heart rate tracing where the baby may be in trouble and you just cannot transport. There's two ways you can go. You could say to the mom, I can't guarantee you the health of your baby, but you're stable. You can transport and pray that the baby's okay. Sometimes the baby will be okay. That's a hard conversation to have. I'll tell you, 9 times out of the 10, mom will say, save my baby at my own expense. Again, not a rational decision, but again, that's what we do with our hearts, not our minds. The husbands will say, save my wife, or the partners will say, save my partner. The moms will say, save my daughter, right? The other alternative is stop right there, call in your most expert people. Do not go deliver immediately. You better call your urologist, your gynecologic oncologist, your trauma surgeon, somebody else who can help you through that heart surgery. If that's all you have, your blood bank, get them getting extra blood to your hospital if you don't have it then. Because if you're at a hospital that only has 2 or 4 units of blood on hand, that's not enough for some of these cases. Call for help. One of my great mentors and the person who trained me, Gary Hankins, used to say, when the boat is sinking, call your friends. Don't go down by yourself. I will say, I want to call my friends in before the boat starts sinking, right? So, but the other thing is, again, if you can deliver, maybe you do, and then don't go through the placenta. Do not go down low. This is where we counsel our patients. Maybe having a big, long vertical incision is safer because we can see better, is better than having your usual low bikini cut, which is nice. It's great for bikinis. It heals better. But in that emergency or that urgent issue, we need to have good exposure. Because we may need to deliver the baby from up top of the uterus. There are ways to sometimes reach higher. If you're thin, you don't have a lot of scar tissue, you've got some flexibility, or we make a big long incision horizontally, but sometimes we still have to go up. If we cut through the placenta, we will surely cause bleeding. So knowing where the placenta is and avoiding it is really helpful. Being attentive to bleeding immediately, stopping the bleeding before it occurs, also important. And then if we can do that, close the uterus, keep the uterus nice and contracted so that it's not filling, and then transporting the patient then may be a very good option. But those are the tips that I have for the unanticipated case, or the case that kind of gets diagnosed right at the time of delivery.
Awesome. I want to say too, great comment from Jamie about the importance of simulation too. We saw a little bit of that at PA Squared, which was actually the highlight for me, getting to see all of the work and preparation that goes into training for these situations and being prepared. So thank you so much, Dr. Fox, for being here today. This has been incredible. And then also, I just wanted to say as well, just thank you so much for everything you do, being a leader in Accreta. We are so grateful to have you here representing patients and working so hard to give us the best outcomes and experiences.
Thank you so much. Let me answer 1 or 2 more questions if I can. I know we're limited on time.
Yeah.
I want to make sure I address the questions from the group. One was, my situation was an undiagnosed and then some subchorionic hemorrhages really early in pregnancy. Hard to say. Subchorionic hemorrhages are super common early in pregnancy. Some of us think it might just be some of the implantation, normal implantation process that leaves a little rim of blood between the placenta and the uterus. So it's hard to say. We see that a lot in very normal pregnancies. But again, it depends on where that was. So I can't say that it was totally related, but it kind of depends more on where the placenta was situated compared to any other prior uterine scars that you had. What else? Oh yeah, simulation. That is one of the ways that we were trying to train our up and coming trainees. I've got a model that I'm trying to publish, and Kristen definitely got to see it using a chicken. Because again, wouldn't it be great if we can at least teach a lot of the very fine-tuned skills without having to teach people while in a patient? But I do think it's critical. This is something for the patients. Yeah, there we go. There's a picture.
Oh, awesome. If you want to see more, yeah, go on our Twitter. We've got some incredible photos from it. It was my favorite session.
Yeah, and but I will say that in our team too, I insist, and it took a long time to get there. We do need the experienced teams, and we will shift to having only the most experienced surgeons in our surgery when things get really rough. But I have to have a fellow in training there. These are people who are doctors but becoming maternal fetal medicine specialists, and I want to have a senior resident there because these are the people who are going to go out and practice medicine in smaller communities or maybe at another center, and they are the people who are going to replace the Dr. Foxes of the world eventually. If they are not seeing what we see at the time of surgery, if they're not seeing how we take our approach, we're not passing on our knowledge and we're failing. In order to become an expert or experienced, you have to start somewhere. And this is really challenging as a patient to hear that we will have learners in our cases because it sounds like we're only letting them do the surgery, that they're doing everything. That is not the case. But from a very personal experience, my daughter, when she was about 9, had a speaker fall on her head while she was at a Taekwondo event, had a little head laceration. I got there quickly. I took her to urgent care, and the intern who was there told my daughter, you know, your mom could probably repair this better than I can. And I told her, the intern, I said, this is my daughter. She is not going to let me stitch up her head. You can ask her, but I don't think she's going to let me do it. And she said, do you want your mom to do this? And she said, no. And I said, yeah, I didn't think she was going to want me to do it. I'm her mom, not her doctor. And as this intern is stitching up her head, she had all her, you know, she was cleared from a CT standpoint, head trauma standpoint. But as this intern was suturing, she said, Dr. Fox, I just want to let you know, I will never forget you because you were the first person who ever let me suture on a live human being, meaning like close the skin at the time of delivery. And I said, well, isn't it a good thing I did? Because here we are, you were fixing my daughter's skin on her face. And she did a great job. She does have her little, you know, what do you call it? Harry Potter mark, but it looks fine. And she's actually very proud of it. She, my daughter, but so that's the point. If we do not, get our trainees actively involved in the surgeries where it's safe to do so with our supervision and do simulation training, they are never going to have the skills that we have. It takes practice, just like learning how to sew, learning how to dance, learning how to do art or a craft, or anything that takes some technical skill. You have to start somewhere. And I know that's kind of scary as a patient to hear that somebody might be working on you, but I really encourage our patients to permit our learners in the room, in their care. And the other reality is if we take all of our learners out of the field, that's one less person who can respond to those emergencies. Even if I have my resident come in and start a blood transfusion or give some orders to get the patient to the OR, if we take them out of the picture and you say, I only want the faculty there, or I only want my doctor there, that actually can do more harm sometimes.
Absolutely. Well, thank you so much, Dr. Fox. This has been incredible. And we're going to bring up Jory again, I think, to close us out. So thank you so much.
You bet.
I just want to close by first thanking Dr. Fox for her time today and by reminding everyone that Accreta Awareness Month, we're only just in the beginning, just halfway into the second week of Accreta Awareness Month. So while you sign off today, would you tell us what you're going to do in the comments, what you're going to commit to doing? You can sign up for our mailing list and keep in touch. Submit your story to our story bank. Designate the National Accreta Foundation as your charity on Amazon Smile. Share your virtual 5K fundraiser or sign up to join us in your community running or walking to raise funds and awareness for the Accreta Foundation. Order gear to show your Accreta Strong pride. Join one of our online support groups. We can't wait to see all the ways this community will step up to help prevent Accreta, promote quality Accreta care, and support Accreta patients and survivors. And I just want to close by making sure that everyone knows how to find past talks that we've held with other experts just like Dr. Fox. So I'm going to bring up The reminder that our past installments are available on our website at preventaccreta.org/accreta-expert. You can also find it in the footer on our page, our homepage. And this live stream will be available really shortly, so you can go back and share it with others that you think would benefit from all of the wisdom that Dr. Fox imparted today. And we look forward to our next installment of the Accreta Expert Series, which will feature an interactive presentation and live Q&A with Dr. Lisa Zuckerwise on the topic of conservative management, which I know that we're all really eager to learn more about. With that, I hope you all have a great week and a great Accreta Awareness Month. Thank you.